at the Patient-Centered Primary Care Collaborative, and I'd like to welcome you to today's webinar. We are having this webinar in celebration of National Primary Care Week as well as National Health Information Technology Week. So we're thrilled to have two fantastic presenters, one from HIMSS and one from URAC, who will both be talking more specifically about telehealth in primary care. And as per usual on our webinars, before we begin, I'd like to just go over a few announcements and housekeeping items. First, just a reminder that our 2015 conference titled Investing in Primary Care, Patients, Professionals, and Payment is just around the corner, and we still have early bird registration. So we encourage you prior to October 8th to come and get registered for our meeting. It's going to be fantastic this year, and if you go to our website, you'll see the agenda, the speakers, and everything else you need to know to get registered. The second item is about how our webinars work, and we ask that you use the webinar software to ask questions or provide comments. You'll see that you can do this by writing in the drop-down question box that's on your screen. During the last 15 minutes of today's presentation, we'll be opening this up for questions and answers. As we always do, we will make these slides and the recorded presentation available on our website within the next 24 hours. So with that, it is my pleasure to introduce our speakers today, Tom Martin and Kyle Ann Green. I'm just going to focus on a few key points from each of their bios, which you can find the full bio on our website, and certainly encourage you to go to our website to get more information on each of our speakers. Dr. Thomas Martin is the director with HIMSS. He is the director with HIMSS that provides support for the connected health community of HIMSS. As most of you know, HIMSS, of course, is a global nonprofit focused on improving health via health information technology, and they've got a special focus on mobile, wireless, and telehealth technologies. Dr. Martin began his career in healthcare, working with the Cleveland Clinic Foundation, and has served on a number of different IT implementation and mobile app development opportunities. Kyle Ann Green is the president and CEO of URAC. Many of you know URAC. It is a national accreditation organization, a longtime member of the Patient-Centered Primary Care Collaborative, Ms. Green has over 40 years of experience in healthcare delivery, insurance strategy, and operations. She is a fantastic leader and an inspiration to many of us who are looking for alignment between clinicians and hospitals and the medical neighborhood and community and patients. And Kyle Ann provides leadership in all those spaces. She herself is a registered nurse and adult nurse practitioner. So with that, thank you both, Tom and Kyle, for being here. We so appreciate our ability to highlight both National Primary Care Week and National Health IT, and to demonstrate that the two, in fact, fit together in very important ways, telemedicine being one of the primary ones. Tom, I'm going to go ahead and ask you to kick it off for us today.
Thanks so much, Marcy. Really appreciate everybody at PCPCC for the invitation. It's always great to share the stage with somebody like Kyle Ann. Really amazing opportunity, I think. Getting into the nuts and bolts of our discussion, I think one of the things that I try to avoid on a regular basis is clearly defining or articulating how we're providing services to our patients. Right now in telehealth, there's lots of discussion around terms like e-health, m-health, digital health, connected health. We could go on and on for probably the next 45 minutes just trying to define what it is we're trying to encompass. I think for the purpose of this discussion, we've got three large swim lanes here that we could maybe talk about in terms of the service delivery itself. The first, and I would just highlight that live video is one of the elements that is a key component of what Medicare is willing to reimburse for or is reimbursing when it comes to telehealth right now. I think the next two big swim lanes that we have, both store and forward and remote patient monitoring, is really where we're seeing some opportunity, some consternation in the marketplace. For those of you who have a cell phone sitting in front of yourselves, who maybe used a couple of mobile apps, all of that technology is really built on the premise of store and forward, whereby that device is looking for network access, and once it finds network access, whether that's your data plan for your cellular communications or a local Wi-Fi, it's looking for that access point to send off information. And then finally, I think one of the opportunities that hopefully we can get some robust discussion on a little bit later on is the concept of remote patient monitoring, whereby we have a number of either consumer or clinical grade electronic devices coming together to provide support for the patient regardless of where they are. And I really emphasize that last point, which is that through all of these, we're moving more towards a delivery system where healthcare can be delivered in an anytime, anywhere fashion or format. So going into telemedicine and why telemedicine is becoming a hot issue right now, I think a couple of things. Given the elements of the Affordable Care Act, the Medicare Shared Savings Programs, and a lot of things that are within an ACO, we're certainly seeing an emphasis on decreased costs and increased quality. Interestingly enough, there was a notice of proposed rulemaking that came out of Health and Human Services around the Medicare Shared Savings Program, where there was some discussion or some opportunities for the agency to grant waivers for the use of telehealth, removing a lot of the restrictions around definitions, removing a lot of the restrictions around originating sites. Sadly, the agency did not go through with that waiver, but I do think there's a number of opportunities here where telehealth is starting to play a role. With the pending meaningful use stage 3 requirements and opportunities for healthcare providers to really engage their patients, there's certainly an awareness of remote and connected technologies to play a role there as well. So in general today, when we talk about telehealth, we're probably talking about not necessarily a workflow, but in an environment where a patient has access to seeking care in an anytime, anywhere fashion or format. I think it's important to realize that a number of disintermediaries or new vendors to the market are leveraging some of the opportunities to reach out to patients in an anytime, anywhere format, whether that's a concierge service or a private payer service. We also have a movement of patients with planned procedures in hospitals where telehealth is supporting them. Some of the recent bundled payments where waivers were granted for the use of telehealth is just one example where telehealth is playing more of a role, not just in a clinical setting or a in a service area setting or a clinical setting, but moving it more into the patient's home. Some other opportunities, some of the recent updates to the physician fee schedule and chronic care management codes, where there are opportunities out there to use non-face-to-face types of encounters to engage with patients when they're not necessarily being seen in a healthcare setting. And finally, some of the opportunities around hospital readmissions. I'm starting to see a number of creative applications of remote patient monitoring whereby hospitals or health systems or providers, large providers are looking to deploy these kits to prevent readmissions as well. So I think this isn't necessarily this isn't a workflow. It's not step by step, but I think these are all elements where we're starting to see telehealth play a role. I'm going to highlight a couple of key figures or facts from both our recent HIMSS Analytics survey on how hospitals are using telemedicine solutions. And I'm also going to highlight some opportunities. HIMSS conducted a physician focus group around November of last year to take a deeper look at telehealth and what some of the barriers and opportunities were around telehealth. So the next couple of slides come from those two major areas. Again, this is the 2015 survey, and this is the number of hospitals or health systems that are reporting having a telehealth type of technology in place. We could see some significant growth year over year as more and more hospitals start to build out their infrastructure around telehealth. I think the notion of just having hub and spoke models whereby a large academic medical center supports rural or outlying areas is becoming less and less the norm, and the number of hospitals and health systems and providers are adopting telehealth solutions more for the concierge or the opportunities to realize some level of comfort or to gain some efficiencies in their system, but it's not always directly tied to incentives. Given that telehealth reimbursements at the Medicare level are quite low, between $12 and $30 million a year. With our focus group, we identified a couple of key barriers around the use of telehealth. The first and foremost is payment. Physicians often cited this as the greatest barrier to use. The restrictions around where a telehealth intervention can occur or originate from is certainly one of the many barriers that are out there. There's also a number of challenges around the definitions that we got into earlier, whereby only a clinical video encounter is the most appropriate intervention right now as Medicare sees it. In terms of technology, technology continues to evolve at a very rapid pace. It's really hard to imagine a world 7 or 8 years ago where an iPhone didn't exist, and we're now on the 6th iteration of the iPhone. Finally, with regards to technology, rural connectivity, some of the providers that I speak with on a regular basis have tremendous challenges when it comes to rural connectivity in terms of both wireline and wireless access points. Through the FCC's Universal Service Fund, there is the Healthcare Connect program, and I'll talk just a little bit more about that in a bit. But again, connectivity issues continue to be a huge technological impediment. And then regulatory, the ability for policy to keep current. When you think about some of the state-based requirements, you might have laws that are still referring to telegraphs or to facsimile machines. So there's certainly some huge challenges around defining the types of technologies. On the reimbursement policy side of things, I think we're starting to see a number of interesting case studies bubble up on the state level in terms of what constitutes a provider encounter or establishment of relationship. You probably don't have to look much farther than Texas or Arkansas to see some of the different approaches that state legislators are taking as it relates to this specific topic. Also some challenges, I'm sure Kylan is going to talk about this a little bit later in terms of just defining what a quality encounter is, or some of the challenges around documentation. Do you need to save terabytes upon terabytes of video data for a patient that you're supporting? On the state levels, I'd certainly highlight the great work that's being done by the Center for Connected Health Policy, which is an AHRQ-funded telehealth resource center. They track a number of the important pieces of legislation that you might need to know at a state level. So I'd certainly highlight, if you have questions around your specific state and what they're doing as it relates to telehealth, to certainly check out the Center for Connected Health Policy. I think they give excellent coverage in terms of what states are doing. However, I think there's a couple of opportunities to maybe think about the ability to expand Medicaid coverage models for dual eligibles. There's also a number of pending pieces of legislation that allow for or remove some of the barriers around state licensing to allow local solutions to local problems. So a couple of things to maybe think about as we progress through National Health IT Week and through the month is opportunities around working with your state medical boards to address issues or to maybe make updates to state or to submit state plan amendments to Medicaid to really call to bear the need to deploy telehealth for some of the dual-eligible populations. Also, state health information exchange models and the need to sort of more robustly engage with the various telehealth business models that are coming to bear. This includes things like concierge and not just some of the fee-for-service types of delivery systems that we're seeing, but to really have health information exchanges support telehealth in a more robust fashion. On the federal level, I did highlight the Universal Service Fund and the Healthcare Connect Fund. For those of you who are unaware and who maybe reside in a rural setting, this is a funding mechanism of about $500 million total, whereby healthcare providers in rural or underserved communities could submit an application to the FCC, and the FCC would cover approximately 65% of the total cost for broadband build-out. Again, there's a number of hurdles and challenges to overcome, I think, in terms of getting together that remaining pot of money, that 35%, for individuals to really address issues around connectivity. So again, that's the Healthcare Connect Fund that's overseen by the Federal Communications Commission. And for those of you who are considering implementing telehealth in a rural setting, I would strongly suggest taking a look at what the funds are. Another thing that I just want to highlight, the Office of National Coordinator for Health IT just last week released their roadmap, where telehealth, e-visits, and remote patient monitoring remains a critical component of their path forward as well. Finally, on some of the last 2 points, we're seeing some interesting discussion out of the American Medical Association and taking a bigger look at telehealth and perhaps updating or providing additional CPT codes that really call out some of these emerging interventions that are out there in the space. Finally, one of the things that our physician panel highlighted was to ensure that CMMI is really exploring to the fullest extent the use and implementation of telehealth. I think one of the challenges as it relates to some of the funding recipients from CMMI is that there's a number of regulatory hoops that they still have to adhere to. So there's still a number of barriers in place for those who are really trying to test innovative payment models or really trying to address or implement innovative pieces of technology as well. So going back to the HIMSS Analytics survey and where healthcare organizations are really trying to address or position telemedicine or telehealth, they're really looking at it for 2 different reasons. That's filling gaps in patient care and the ability to offer care for which services were not otherwise available. I think what's really interesting is that they're not really driven by opportunities for overall cost reduction when implementing this. And I think it goes back to the statement that I had earlier, is that this is not necessarily being driven by policy or reimbursement right now, but it's because individuals recognize that it's the most efficient and effective way to engage their patient populations. Some other primary drivers of what, this is one of the questions that we asked, and the real question behind this graph is define what your telehealth service looks like in 5 years. So we asked the respondents to say, 5 years from now, our goals of our telemedicine program or our telehealth program is what? And again, it's the expansion and the need to add other specialties, followed by the opportunity to enhance provider consultations and communication. Again, not necessarily grounded in cost savings or the ability to really extract funding from either private payers or public payers, but again, just sort of that need or that understanding that this is quickly becoming a best practice that needs to be employed. So again, these are sort of my last 2 or 3 slides. This is National Health IT Week, all week. We will be going to HIMSS as an organization. We'll be going to the Hill with about 300 of our members on Thursday to ask Congress to address a couple of things. And these next 6 areas are really where we are focusing on. First is to change the definition of originating sites. By confining this to just clinical type settings, we ignore the fact that our patients spend the vast majority of their time at the home or outside the view of a healthcare provider. And it's really, as we make the shift to accountable care organizations, as we make the shift to value-based purchasing, it's going to be understanding what those patients are doing when they're not in front of you that has the greatest opportunity to affect change. Second, the need to eliminate the geographic restrictions on telehealth. The need to open this up to metropolitan areas. I think it's really important to highlight that there's vast areas that are metropolitan in nature. Think about Houston, right, where there may be large geographic areas of medically underserved individuals. So to remove some of the restrictions around tying this just to health professionals shortage areas in rural locations is a major opportunity. Third, again, I highlighted the growing role of our mobile devices. There's definitely a need to remove some of the store and forward limitations as we start to think about population health and a number of the digital platforms that are playing a role in population health. There's certainly a need to remove some of those requirements. Also, the movement as it relates to store and forward, the opportunities to expand modalities just beyond the real-time voice and video, to build out and create an opportunity for remote patient monitoring and store and forward platforms. And then the last two, opportunities for Congress to specifically dictate to CMS some of the CPT codes that they can and should reimburse for to cover in-home remote monitoring or other types of non-centralized data aggregation and analysis. And while I'm sure it's an important issue to a number of the folks on the phone, we really need to think about ways to harmonize both federal and state efforts around licensing. So the opportunity for patients to seek providers across state boundaries is a huge opportunity in the system. So in summary, some organizational needs and next steps. Obviously, the opportunity to expand mobile and wireless technologies. Removement of restrictive definitions is a huge opportunity. Some of the things that we're doing at HIMSS is working with the American Medical Association to determine some of the opportunities to further refine the definitions of these services or to get a better understanding of the technology at play. I do want to invite everybody on the phone who's maybe in the DC area or interested specifically in connected health, telehealth, and remote patient monitoring to perhaps join us next November in Washington, DC, where we'll be addressing some of these issues and taking a look at them in a bit more depth. And finally, I want to highlight some of the resources that we've done. The survey that I mentioned is up here. It's free and available to providers through HIMSS Analytics, as well as the focus groups, some of the other findings that we had there. And one of the things that I maybe didn't highlight enough is that we do have a resource that really aggregates the wide variety of funding sources that are out there. So with that, I believe I transition off to Kyle-Ann.
Well, good afternoon, and I really appreciate the invitation from PCPCC to talk specifically about quality and accreditation and why telehealth. I'm going to expand a little bit on some of the things that Dr. Martin talked to you about, and I'm going to specifically talk about why the telehealth was different, how it was that URAC became involved in telehealth, and some of the things that we're seeing in terms of the standards that are in development, the program that's in development, and the recent public comment period that we had for both the standards and the measurement that we're going to use to derive quality measures. So why telehealth? I think you've heard a lot already today and seen a lot just in the popular press about everything that's happening specifically in the area of telehealth. It's growing exponentially, and the diversity of what we consider to be telehealth or telemedicine is increasing at the same time that you're seeing the growth. The reason why URAC got involved in the quality monitoring process and validation of telehealth was the community of interest. We were actually approached by a subset of the telehealth community to develop a programmatic approach to accreditation specific to certain areas of telehealth. So what we're going to talk about a little bit today is how that's been narrowed down, and to the extent that it's been narrowed down, what's behind that, and why is that important when you're talking about an accrediting process. So you probably know that the American Telemedicine Association has already developed standards. In fact, they had standards that were launched in the summer of 2014. So it's been over a year that they've had standards that they developed in conjunction with their membership as an association that have been actually pretty popular in terms of the uptake of the use of the standards themselves. So why did we need an accreditation program? I think there are probably two reasons for that. First of all, it's very difficult to develop standards when you have really no common definition, no uniformity of approach. We understand that there's a concern for public safety. We're hearing a lot in the states about the need for the preservation of doctor-patient relationships, and just exactly how does that happen in a more virtual setting. We had a release of a public document just about a year ago, shortly after ATA released their standards, that talks specifically about the regulatory structure in the 50 states. And it's, if you've seen one, you've seen one. So there's a lot of diversity in everything that is now telehealth. And Dr. Martin just talked about the inconsistency in the reimbursement schemes, and what he characterizes is the need to take a second look. The growth that we are talking about, this is the slide that I have here is really just an estimate by a consulting group that talks about what they think is going to happen with the explosion in telehealth. But if you look at it, it has a combined annual growth rate of close to 40%, and that's almost unheard of in healthcare. So what happens when you have that type of growth with all these uncertainties associated with telehealth? Here's just another look at another individual who's part of an organization that's looking at the growth. And no matter whose numbers you use, I think it's undeniable that the growth is extensive, and the stimulation of everything that's happening, making that just something that will continue throughout at least the next half a decade. Dr. Martin talked about what is stimulating the growth in telehealth. I won't go over that in any great detail. You've already heard some very specific things about that. With respect to interest, talked a little bit about the public document that was produced by Epstein, Becker, and Green, a law firm here in Washington, D.C., that talked about multiple state interests, who the federal stakeholders were, and then there's been considerable interest on the part of commercial payers, several in particular, to look at improving access and reducing costs by encouraging certain telehealth programs, including some of the more commonly known doctor-to-patient telephonic interventions. So there's a significant interest on the part of the commercial payers as well, because they believe that access will be improved and costs may actually go down. And whenever you have that dynamic, the community of interest widens. So here's why telehealth accreditation, as URAC is approaching it, is a little bit different. And I'll tell you why the telehealth part is different and what the approach is going to be. I mentioned that we had a community of interest in developing a program. We actually had a set of a roundtable practitioners that got together as a part of, first of all, an educational effort, and then eventually a community of interest or an affinity group that believed that one of the things that was important to them to preserve what they thought was important with respect to quality was the development of an accreditation program that was actually done by an independent third-party accreditor. And so this community of interest, this group of practitioners, the majority of whom were physicians, approached URAC and asked about working collaboratively to establish such a program. Now, that's the first divergence from what is traditionally our model for accreditation and standards development. We generally have a lot of interest in it, but most of it is stimulated by friction points or by a need of to actually look at the intersections between providers, practitioners, consumers, and payers. And for the 25 years that we've been in existence, much of what has stimulated our program growth has been just that, either friction points or new intersections between practitioners and patients and payers. So the fact that we had a very specific group with a very specific notion about what they wanted in a program was a bit different. Now, the problem that we had in the initial days was we're a third-party independent group that sets standards based on the advice of multiple stakeholders. So where we had a community of interest with some very specific ideas about the development of quality measures and quality standards, there's far more in terms of the stakeholder interest out there that could essentially create for us a new starting point. What is pretty much a wide open field. There is no community of practice about what happens in telehealth. So there's no community standard and therefore no standard of care. So where do you begin? Well, we began by inviting additional stakeholders into an advisory group to talk specifically about how they would narrow the applicability without making the program so narrow that it was completely exclusionary and not really of sufficient scope to capture enough of the activity to really move the bar on quality. So if it was a very narrow definition that we used in order to create standards for telehealth, we had little impact because of everything that was happening outside of that sphere of influence. So what we did was we focused on what I talked about in terms of the intersection of the practitioner to the consumer or practitioner to practitioner, where the interaction was facilitated by technology. So that leaves out certain types of patient monitoring where there's no practitioner interaction that is, as Dr. Martin described, real time. And that leaves out the consumer to the mHealth or the application of devices and programs where there's no practitioner connected to it in any real fashion. So in narrowing, we narrowed it to what is still a sizable part of the telehealth field, but it still involves practitioners, in some cases physicians, in some cases practitioners such as nurses, PAs, people who are actually directing patient care in a more traditional setting, with the exception of the fact that it's enabled by technology. Before I talk specifically about the standards, I'd like to add a little bit of color from some personal experience that I had with this prior to coming to URAC. I worked on an executive team in a large health system, and it was a nonprofit system that actually did quite well. But one of the critical issues that we had was the shortage of physicians who would actually be able to come to the hospitals or come to the facilities because they were in the community practicing, and the economic associated with not seeing patients in offices or doing surgery or other procedures in a clinical setting and actually moving physically to either a hospital or a different setting was a very an economic model that was particularly troublesome. So it was difficult to have access, in part for certain specialties, to patients, and so telehealth became a very important part of our program. We started using it in the areas of the underserved population so that we could get specialty care to the underserved population. We could actually have the patient on site in our clinics, and the specialist came to us via televideo. And that worked quite well. There was no reimbursement per se. These were individuals that the health system actually provided care for without reimbursement. So the doctors in the community who were willing to provide what we called indigent care, but just didn't have the economic wherewithal to travel to do it, agreed to do it. Is part of their mission and their altruism, but we made it much easier for them to do it, and we were quite successful with that program. The other program that we established was particularly in behavioral health. I think if you speak with any physicians who are in emergency departments or who do urgent care, they will tell you that there's a significant need for consultations and not enough practitioners to really provide those. So that was the other area that we developed the telehealth programs. Again, it was facility to facility, practitioner to patient, real-time intervention, and the question of reimbursement did not come up, but certainly that's one of the driving forces for today. When you look at the standards for the telehealth program, which have now been out for public comment, which we do with all of our standards, and the measures, which is still open for public comment. And if you're interested, it is on the URAC website. It'll tell you exactly where to go to see all of that. But if you look at the program standards, you'll realize that there are aspects of it that are really core to any quality validation in healthcare. And then there are others that are a bit different. The ones that are a bit different than the more traditional programs that we have are the risk management strategies and the risk management tactics take a different form than what we see in some of our other programs. I will tell you that the regulatory compliance program and internal controls is not much different because, like telehealth, the other accrediting programs that we have for healthcare management functions are regulated by the federal government and by the states, and that regulation and law is very diverse depending on where you are. The information systems confidentiality and security is a bit different because of the type of information technology that's being used. So there was a bit different approach there. The healthcare ethics was a bit different than some of the other core programs that we have because of the lack of connectedness in terms of physical connectedness and the issue of patients' rights and practitioner responsibility. The staff credentialing is a bit different because there's not necessarily a uniform institution that's operating the programs. Leadership was a bit different, and decision support tools were a bit different. Much of the rest of these standards don't look a lot different just because we're talking about telehealth than if we were talking about, for example, patient-centered medical home or the clinically integrated network. So the tools and techniques that we use to get the advisory group to help us establish the standards really focused on a couple of areas where there had to be some significant deviation, and yet there was recognition that there is some commonality with what we're trying to accomplish with things that are happening today. So how does this all fit in to what we do with respect to accrediting? We really see, and this is where the primary care comes in, we really see that telehealth has the ability to make a difference starting at that very first point of healthcare management, which is the patient-centered medical home. So if you look back at what I said with respect to the standards, you'll understand why some of the expectations were already well established. We believe that as you move toward the more highly integrated types of organizations, from clinically integrated networks eventually to accountable care, where physicians, networks, and others are taking responsibility for risk associated with accountable care, the instance of telehealth and telehealth's usefulness will actually probably increase. Another reason why the standards are really critically important at this point in the evolution of what we're trying to do. Do you want to go to the Q&A part of the program?
I would, excuse me, if you're ready.
Yes.
Terrific.
I am.
Well, I want to thank you both for painting, I think, a very clear picture of where we're headed relative to telehealth, telemedicine. Here's a question, and I will be turning this over to Tara in a moment, who is going to be pulling questions from our participants. But a quick question I had is, Tom outlined the barriers, Kyle outlined the community of practice gap, and clearly this is going to be a part of the future of health delivery. Could you provide a bit of an example for where telehealth changes from being kind of a motherhood and apple pie concept into one that is more problematic, first from the perspective of providers, and then second from the perspective of patients? Because I do think we often think of telemedicine as being a very logical solution. Tom pointed out folks want to stay in their home if they can. Anyone who's had an ill family member understands that. So why can't we just flip a switch and hit go and start paying for this? There are reasons, and we've talked about the barriers, but tell maybe a more practical story. Tom, you alluded to Texas. Maybe you want to tell us from the perspective of some of the physicians in Texas what their beef is about telemedicine. And then maybe Kyle can tell us from the perspective of patients what patients might be concerned about where telemedicine is concerned.
I'm not going to speak for every physician in Texas, but I'll maybe try to break down the question this way. I think, by and large, flipping the switch on telehealth is complex for a number of reasons. It's complex because of how we've defined the service intervention. It's complex because we've defined the location where it has to originate from. In certain states, to your question, we've defined when a patient can actually make a decision to see a healthcare provider and use this type of technology, right? So you've got those three things playing out right now, and I think the slide that Kyle Ann just had up is a really great challenge or focus point for where we're going, right? We need to move away from simply having telehealth as an oddity or a service delivery that's really constrained for a few, right? And I think as we transition to accountable care organizations, as we transition to patient-centered medical home practices, you've really got to employ technology as another tool in the toolbox, where if somebody wants to use the saw to trim their tree or cut PVC pipe, they can use that tool. So I think, that's really the opportunity where we can transition telehealth from maybe circus oddity or challenge, too many barriers to implement, to really making it a tool in the toolbox and a service delivery system that is entirely focused on how the patient chooses to receive their care.
And I liked your whole saw analogy.
So let me take a little bit different viewpoint. And to some extent, I think that we hear this from the practitioners and other stakeholders that are involved in our standards development process. The caution that they have is that in moving from more organized and then almost an institutional approach, you get into areas where there is no real understanding of who's governing, who's controlling, who's accountable for the patient. And it's not to say that the other things that we're looking at in the spectrum of what is telehealth are bad, or that they shouldn't be explored and advanced, and in some cases that they shouldn't be funded in some way beyond just the consumer themselves. But there is a concern on the part of the health community, particularly the practitioners, that absent some form of oversight, there can be a lot that can happen that has the potential to harm. And what do you do about that? And how do you make sure that you can explore options that make a more effective system without introducing too much risk associated with lack of adequate oversight?
And I suspect that the patients themselves recognize that. Tom talked about the different kinds of technologies as they learn a technology on their end. Let's say they're using remote monitoring. We need to have redundant systems in place to ensure the accuracy of the information being transmitted, so that the diagnosis is appropriate, the treatment is appropriate. I mean, this is really about patient safety at the end of the day. Is that a fair way to put it?
Yes, I think it is. I think if you look at, and I'll use primary care and the patient-centered medical home as an example. The work that's being done there is to help not just empower the patient, but connect the patient to resources for their health, and to make sure that in the coordination of that, information gets shared, the three-way information, that what is planned for the patient is allows them some self-determination, some education, all the kinds of things that I think primary care is known for. But if you move too far out of that nuclear approach to empowering patients, to where they're empowering themselves and engaging directly with organizations that are not that don't have direct oversight by some other organization, regulatory scheme, I think there's nervousness, to be honest with you, on the part of providers, physicians in particular.
Yep, I've certainly heard that expressed in several conversations that I've had with clinicians. Tara, I know we've got some questions teed up there. I might turn it over to you to take it from here.
Sure, thank you, Marcy. So we've received quite a few questions. I want to stick to the ones that we've received recently, since we're talking about that now, and I'll go back to some of the earlier questions. But we have some questions regarding specific to accreditation, and Callahan, I think if you want to weigh in first, but I think Tom as well, you'll have a good viewpoint on this as well. And this question is related to, do you believe that the accreditation will be a requirement for primary care providers who use telehealth practices? So looking at, is there movement in private or public markets towards, requiring practices to become accredited, or what's kind of, where are we moving in this space?
Right now it's entirely voluntary. And that is how the program that we have is designed, as well as the standards that were developed by the ATA. So there is no clear indication that accreditation will be required on the part of either the payers or the regulators. One of the things that I think might be important to the primary care physicians is if they work with an organization that supports their patients in telehealth. An accreditation may be an assurance that certain things are happening, there's a certain level of oversight and that kind of thing. I don't envision at this point, based on what we know, that there will be requirements for primary care physicians to be accredited for telehealth specifically. It's still all voluntary.
I'll maybe jump onto that with the notion that I think the closest example I have that I could offer up is the Meaningful Use program with certified EHR technology. I think if we offer that up to regulators, it can become a somewhat challenging scope or a slippery slope for folks to really kind of deliver care in an innovative way, because the moment you introduce highly regulated standards, you get a lot of folks who just build to the standard, right? And one of the things that we're trying to kind of subtly address here is the nuance of a tailored healthcare experience to folks where they are, and ensuring that that experience is really high quality. And I think right now voluntary certification is one opportunity, but I don't think it necessarily has to be it can happen at a very institutional level, a dedication to quality. So we just did a site visit to the University of Pittsburgh Medical Center that has a very advanced telehealth service delivery line. And, they have everything from fellowships to training for healthcare providers who are leveraging virtual visits, right? And And that's really an organizational dedication to ensuring that quality is adhered to. So I think, you know, looking at the Meaningful Use Program certified EHR technology, the question is, do we want to continue to sort of build to some sort of standard or let the free market work? And I'm a healthcare economist, which is why I give a lot of really kind of bad examples, right? Whenever you talk about economics, you've got to at least make it a little bit lively. But I think if we can allow free market forces to work, we start to get that tool in the toolbox mentality for this.
Thanks, Tom. So I'm going to ask one more question, and then I'll close it up. We have a lot of interest amongst our members and among the participants in terms of in terms of clinical integration and transformation within the whole medical neighborhood. So there's a question specifically on how are behavioral health and mental health and even dentistry and nutrition, how are these being integrated into telehealth?
Behavioral health is probably one of the more foundational programs that use telehealth, and in certain communities, it's almost an expectation that that is how a certain portion of the care will be delivered because of the need to integrate that more fully on the medical side of the community, particularly with the understanding that the services are provided a bit differently, but there's still an expectation that there's parity, which is something that's been a very focused effort for a number of years now, particularly on the reimbursement side. I think the more distant services associated with nutrition and other services where telehealth can provide information that goes to many people at the same time in real time, there's a tremendous opportunity to reach more people through a telehealth solution than what we're able to provide today. And as Dr. Martin said, if you can do it as close to their home as possible, where it is as convenient as it can be, they are more likely to access the information available.
Thank you. I think that's a great point and a great way to close out our webinar. So thank you all. Thank you, Dr. Martin and Kyle-Ann for presenting to us today, and of course all of our participants for this who attended this webinar. As a reminder, the slides and the recorded presentation will be posted on PCPCC's website within the next 24 hours. So once it's available, you can access them at pcpcc.org/webinars. And I just wanted to invite you all as well to participate. We have a webinar tomorrow featuring Plaintree, and they're going to be talking about their patient-centered designation program as the framework for accelerating patient-centered transformation and improving outcomes. You can join us tomorrow at 2 o'clock Eastern Time, and you can register for that webinar on our website. So thank you, everyone, and have a wonderful afternoon.
Thank you.
Thank you, Tara.